That's a good response. That is also a good, much better response. And there is fixation suppression. So that's how you read. The question is, how do you read and measure response? It's very simple. Try to do it frequently. So back to your patient. So your patient now has bilateral hearing loss, low frequency, high frequency, fluctuating, as you said, and right reduced vestibular function, and the patient had injection, right? Which ear and why? The right ear. With what medication? What steroid? That's Right. And twice. Presumably because the patient has Meniere's disease or autoimmune inner ear disease. That's good. What other treatment the patient had? Just the injection?
What's the response of the injection?
Not in the injection. I think it's just fluctuation. The previous milligram was more than that I do, but to prevent it improve fluctuation. Both is not in the injection.
So we are not sure if the injection
All right. So patient was injected, and what happened? Did the patient take any other medications? Beta-cert. How does beta-cert work, if I may ask? Do you know? Who knows how beta-cert works? You're an ENT surgeon. I'm sorry, I have to put you on the spot. You know? Right. Please go back, read the literature on beta-cert and find out how it works. It's an antihistamine, as opposed to what they say that's a histaminic medication. It is not. It's an antihistamine. And the vestibular system actually responds to antihistamines. Okay, so what happened to the patient? In both ears? In the injected ear. How about the hearing? Did the hearing improve?
Yes.
Good. Did they inject the other ear?
No, in both ears. I think due to the fluctuation of my ear. Due to injection. I get a normal injection.
Is due to the injection.
But
both ears are
That's good. That's wonderful. And the patient's still on beta-cert, stagiron, oxycron, half of the baraka, Egyptian mummy powder. I mean, I see this in the States, and I say exactly, by the way, this is my style of talking, because, again, physicians in the United States are not trained in, the majority of them at least, are not trained in dealing with dizziness. They just deal with dizziness because they have to deal with dizziness.
حاجة عندنا عامل السلام بنايف والميوزة من ضمن الحاجات اللي وصلتها في السلام مثلا الميديك 40 ميديك ده موجود في السيكشن دي البيتا هيستين حاجات
It's on vibration. Well, did you hear it? I didn't. I mean, I sometimes and I actually.
The research, in the literature, الناس بيكتبوا كده تقريبا with the medical treatment, the magnesium, the what can we?
Well, the vestibular system responds to a variety of medications differently. For example, the vestibular system can respond to benzodiazepines, Valium, Xanax, and Actived, and what have you. That's a good vestibular suppressant. Antihistamines, because the vestibular system peripherally and centrally have histaminic receptors, both H1 and H3, so that it would respond. It may even respond to some of the central medications like Tropamax and anti-seizure medications or what have you. The trouble is with any of these medications, we don't have really long-term placebo-controlled comparative studies. and until such time, it's all empirical. If it works, fine, as long as it's cheap and the patient is really struggling to pay their medication. I have patients in there that things cannot pay for their medications. So that's what I kind of keep in mind. If you, the rule of thumb is, you put a medication on a drug A, and in 3 months, there hasn't been at least 50% improvement in patient symptoms in the clinical picture, that medicine is not working for this patient. And the patients are very good. The patient will say, oh yeah, I'm wonderful. I don't want to come for follow-up. So, books are good. All of them. Medicine and non-medicine. But you really don't need to follow them to the letter. You have to develop your own expertise and your own comfort with dealing with these patients. Now, this patient should, assuming that he had true bilateral fluctuating hearing loss, in my opinion, should have also had some oral steroids, and if the patient has significant pulmonary stimulus, cut down salt, sugar, the bad things, and maybe diuretics. Yeah. Because of hydrops. Hydrops, the treatment for hydrops is also bad if they are salt sensitive. And you can ask your patients if they are salt sensitive when you eat whatever, whatever the salt.
I guess it's the instructions only, but I'm informed to come after 1 month. Even
That's good.
steroid methods, 5
No.
How much is
And if it is truly immune mediated, and it's both ears, and the clinical history is mechanical, meaning bilateral, progressive, sensory neural hearing loss with no vertigo or facial nerve issues, that's the classical definition of immune inner ear disease. We put them on 60 milligrams a day, 1 dose, for 1 month, and then see them after 1 month, and my hearing aid is changing the program on me. And depending on the response, if they respond well, they take very slowly. If they don't respond well, then they're not going to respond to the steroid. Some don't. If they respond well, I taper them down if they're tolerating the steroids by 10 milligrams every month. And in the end of the 4 or 5 months, if they become steroid dependent, we send them to rheumatology to give them the medicine that we use as methotrexate. That's a very small number of patients that it's not the majority of patients we see. My practice is really otology, neurology. I see tons of many of those patients. So don't come to conclusion that this is autoimmune disease. Definitely if it is 1 ear, because I have seen patients here in Egypt, 1 ear, and it's called autoimmune inner ear disease. It has to be bilateral. Somebody else? Yes. I'm translation because I'm not going to be able to do it. I'm sorry. Lab investigation. Very good question. Look, you have to get the basic labs, CBC, differential, and electrolytes, and the sed rate or C-reactive protein, CRP. Right? And I would get the thyroid function test and the hemoglobin A1C. Right? Now, is there any additional immune test? You can get rheumatoid factor and ANA, anti-nuclear antibody. We used to get the 68 kilodalton and the lymphocyte transformation test, but honestly, they're very expensive. And positive or negative, you have to treat the patient because you treat the patient clinically. No, I mean, if the ANA was a different subtypes is positive, it kind of makes you, as a clinical picture,